Welcome to the Catalyst Podcast. I'm your host, Charles Epstein. Joining me today is Joe E. Glass, a senior research scientist with Chestnut Health Systems. Dr. Glass's research seeks to identify how effective interventions for alcohol and drug use can reach more people. Much of Joe's work aims to develop, test, and implement modern models of care that proactively deliver novel addiction treatments and provide support to people while they seek treatment. Joe, hey, how are you?
Hey, doing great, Charles. Yeah, thanks for doing this. Appreciate it.
Yeah, so I understand that you are sort of in the midst of a move from where Seattle to Eugene, Oregon, correct?
Yeah, that's right. Yeah, just moved into Eugene last week.
Oh, nice, nice. Yeah, it certainly takes a while to get settled. That feels sort of like a horizontal move, Seattle to Eugene. If you take my meaning, it's not like you're going, further south down the coast. You're not going to the other coast, the East Coast. It seems like a reasonably incremental move, if you take my
Yeah,
meaning.
it that's interesting. It does feel very incremental. That's actually a really good way to put it. Staying in the Northwest, the same region. It's not a huge it's not a huge switch. It's a lot smaller. Eugene is really peaceful. It's quiet. It's beautiful. There's rivers. Everything's right there, and it's a lot. It feels like really easy living. I'm just getting to know it, but you drive. Everything's within 15 minutes, much closer usually. The other day, I'm moving into an apartment, and so I've got a lot of errands to run. And I usually leave a whole afternoon to do errands. But you only need an hour here. You can drive from end to end of the city within, 10 minutes. So you can get a lot done. It's nice.
And you're fairly new to Chestnut, yes?
Yes. Yeah. Chestnut. I just joined Chestnut on May 30th. So it's been just over a month.
Oh, wow. And where were you before this?
I was at Kaiser Permanente Washington Health Research Institute up in
Hmm.
Seattle. I was there for 9 years.
Oh, nice. Actually, when we spoke last week to prepare for this, you said something that I found very interesting. I'm sure some of my Chestnut colleagues find interesting, that when you were considering taking this position, you checked out some of our podcasts to get familiar with some of your, well, now your cohort, now your colleagues, and it sort of gave you valuable insight into, the team and the people. That was kind of fascinating to learn.
Yeah, it really helped me. I so appreciated having access to all these, kind of long form conversations that you had with my colleagues. It's totally a new thing to be able to just listen to the perspectives and the passions and some of the kind of types of research that people do without even flying out to Eugene and having these conversations with people. It's also nice to kind of be an observer. It's a really kind of a great way to learn about a place and just get a feel for it. Kind of felt like like I had the answers to the test, if you know what I mean. Kind of felt
You
like
mentioned it was sort of a cheat code.
yes, exactly. So it
Yeah.
was great, so helpful. So thanks for doing these.
Yeah, no, that's been part of the fun actually of doing these podcasts. So almost like an unintended positive consequence where the Chestnut Lighthouse people who are being interviewed are learning about their cohort in a deeper, more familiar way than they ever did. So it really has that real benefit. And I think people come away feeling very prideful about their colleagues and about the work and the caliber of the work they're doing and the caliber of the people that they're working with.
Yes, exactly. And in fact, what I didn't mention is that, listening to the philosophy, everybody's philosophy and kind of, their background and what really drives them, that was actually part of what just solidified my decision to come here. It's clear that there's a great group of people who are really passionate about what they do, and who have a lot of real life experiences that I felt like I could connect to. So yeah, so huge fan of the podcast. Thanks, Charles.
Yeah, and it's also, we'll get to it in a second. I want to get too wrapped up in this, but it's really interesting. I just had an interesting conversation with somebody about work. and why it's important that work be meaningful. It's not always meaningful. Sometimes, you go to work and you're clocking in and you're clocking out and you're getting a paycheck, and it's important and to be able to derive meaning and deep satisfaction. That's also been an eye-opening experience on this end as a podcaster, speaking to all of your colleagues. Nobody goes into this work, at least nobody I've spoken to, because it's just a job of work. That's really refreshing and I find deeply interesting. Anyway, Joe, I really appreciate this, particularly in the midst of all the craziness that accompanies any kind of move, even if it's incremental or otherwise. A move is a move. It's just like there's no such thing as minor surgery. When you're undergoing the surgery, there's no such thing as minor surgery.
Yeah, it's a it's an on or off. You're either, yeah, I gotcha.
Yeah,
Yeah, no,
yeah.
moving is tough. I appreciate you recognizing that, but yeah,
Oh, for sure.
glad to make time for this.
For sure. So let me back up a second. You majored in psychology as an undergraduate and earned your PhD in social work several years ago. What compelled you to get into this work?
That's a really good question. It wasn't really a clear path, to be honest. I started college in my young 20s. When back then as a young lad, I was having a lot of fun, working on cars, spending a lot of time with friends, and really, but my passion then was automobiles. I liked electronics, old muscle cars, and I also really liked computers. Those were the days of dial-up modems, and very early broadband internet. And so it was kind of a mistake to go into psychology. I started volunteering at a crisis center in the greater Lansing area in Michigan, where I grew up, and most of the people who volunteered with me were college students and psychology majors. So it was a crisis counseling um, agency, and that was just great for me. I got exposed to college life. I took some community college classes, focusing on college prep, some basic writing and math. And I went to Michigan State, so it's the college in my hometown. And so, to be honest, even then, I still didn't know what I wanted to do. But I eventually chose psychology just because it was just totally interesting to me. My friends were doing it, but that's not really why I did. I just felt through my exposure to this volunteer work that I did, I just felt like it was wild that you could help somebody change their outlook on life just by talking to them. And so just the psychology classes were interesting to me, and it felt like something I wanted to try. So, and kind of similarly, social work in particular. So I did a master's at Michigan, University of Michigan, and then a PhD in social work at Washington University. And my initial kind of entry into the social work profession, that was totally by chance as well. My best friend was in the School of Social Work at University of Michigan, and he loved it. I think at one point he was working two or three social service jobs while also volunteering at the same place that I did, and going to U of M and doing an internship at the Department of Veterans Affairs hospital. So that was his path, and I kind of followed it in his footsteps, just through witnessing his excitement and just thinking about what he did, just thinking it was really cool. So that ended up just being one of the best career decisions I made. At the
Yeah.
VA, that's where I met my boss. Was really lucky. There was a lot of research being done at the VA in Ann Arbor, and it was on substance use. And I just really love the people there who are doing the research. I thought the research that they were doing totally reflected what I was seeing clinically as a social worker. And everything kind of just went from there.
So you were there for just under 4 years, correct?
A little bit longer than that. Yeah, I was,
Oh,
I did an internship there, and then I worked remotely as a PhD student. And I also do a lot of service for the VA, mostly on the scientific side. So doing grant reviews, I did that for a while, and I also do research studies with them. So I've kind of never truly left the VA, but I haven't been employed there for quite a long time.
And this is kind of a general question, but is there anything in particular you learned there? Anything that was eye-opening and something that you've afterwards been able to apply to your work going forward?
Absolutely. Being at the VA, it was one of the greatest experiences I've had. It was, I think one of the best things is just the experiences there. I got to, my time at the VA as a clinician, I was working with veterans and their families. It was really humbling. And when I was just when I worked there, I was just a little bit older than some of the guys who were just coming back from the Iraq War. So I worked there, in the 2004 and after that. But really, the biggest population that I worked with were folks who were my mom's and dad's age, so the Vietnam era veterans. And I was also able to get to work with World War II veterans, and
Oh,
everybody in between. So it was, it was a really eye-opening experience in terms of the people I worked with, but also VA, the Veterans Health Administration hospital systems. It's one of the most unique systems I think that's out there. I actually think it's probably the best. It's, what you have at the VA, it's an interconnected system of care. So they have the ability to address somebody's medical needs, their financial needs, their mental health needs, all within one organization. And I was a social worker. I worked in a number of capacities, but just as an example of what they're able to do, when I was working in the psychiatric triage, people would come to the hospital for medical problems. So, they go to urgent care or the emergency department with like an acute medical need. And in that setting, it was often identified that folks were struggling with substance use or mental health problems. And so, we'd see them, we'd see these folks totally unscheduled, and we could link them to care right away. And not just right away, but in the walls of the same building. So, if a veteran needed help with their healthcare benefits, I could walk them upstairs.
mm,
If they needed help for substance use, I could walk them down the hall to the substance use clinic. And so it's not just the services though there that are so great, but at the VA, it's kind of a community. So as a social worker working there, I would eat in the same cafeteria as the veterans who I was there to serve, and so we'd have interactions there in the hallways. And I just think, at the VA, it really fosters this ability to make a connection with people on a human level,
yeah.
even as a clinician. So it goes really far in building trust. And I just don't see anything like that in the private sector.
It's so interesting you say that because there's this general misnomer, I would go so far as to call it a myth, that federal agencies, government agencies generally are inefficient. Their technology is sort of old and kludgy and all that's kind of interesting because the whole Doge experience, they went in there assuming they're going to find all this waste, fraud, and abuse, but they really didn't find much of that. And I always say when people pose this idea that the public sector is not as efficient or that really, really top people gravitate to the private sector and not the public sector, my first reaction was, well, how much experience have you had working in the private sector? There are quite a lot of incompetence working in the private sector. And if you haven't experienced that, you've not done any significant work in the private sector. But put that aside. I want to actually ask a related question. I'm kind of curious. If you're a football fan, you know what an audible is. When a quarterback comes up to the line of scrimmage and sees a different defense and improvises a play, goes off of the scripted play. So I'm wondering, you are interacting with an Iraq War vet. You're interacting with a Vietnam War vet. You're interacting with a WW2 vet. Very, very, very different sensibilities. My dad was a World War II vet, And I think he kind of generalized it. They were kind of buttoned up. Very few World War II vets are really forthcoming about talking about their experiences. So I'm assuming there are very, very different sensibilities with those three very distinct cohorts. I'm curious if you had to consciously call a so-called audible at the line when you're dealing with one than the other than the other.
Oh, that's an interesting question. Yeah, no, I heard the same thing about my grandfather, who was a World War II vet, in terms of, I think maybe people, then didn't, kind of want to naturally just, speak about their experiences. But I'm sure that varied, everybody's different. I'm not sure, in terms of differences between, people from different, I guess, war cohorts. I mean, I think one of the things that struck me the most is actually just how much people across each cohort would support one another. I feel like it was, the largest population, was the Vietnam era people there, and really, when you get when you see folks in a room, it, that are from these different areas, and I think it may also have to do with age, but everybody there, they were really just supportive of the people who are newly coming back, in terms of sharing their experiences, and just everybody wants everybody else to do well, so I think that's the biggest thing that I saw in interactions across those cohorts. Just the
Yeah,
camaraderie was there's nothing like it.
very interesting. Last question about this, and then we'll get to your current work. As you know, the department is on track to reduce its workforce by approximately 30,000 positions by the end of the fiscal year 2025, primarily through attrition, deferred resignations, retirements, and a government-wide hiring freeze. Any thoughts on how this may affect the agency?
Well, to be honest, I haven't stayed caught up with some of the new legislation or actions that are, coming down the pike. With moving and with a new job, but I will tell you this, is that, as I said, the VA is one of the best systems out there, and a lot of veterans really need it, and they deserve it. We made that commitment to them as a country in exchange for what they've done for us, and for our country. So I do get very nervous when I see that, any decisions being made that could potentially reduce services. Like in the distant past, I can't remember exactly when it was, maybe a decade or more ago. It's my understanding that there were some attempts to scale back funding for VA and to direct those funds elsewhere, namely to allow veterans to get services outside of VA. And I remember at the time that scared me a lot too, because when you think about any dismantling of a system that's so strong and unique, do get scared about it, and I was worried. And at the same time, I also had this feeling of, well, I also strongly supported providing veterans with more choice. Maybe not every person eligible for VA services wanted to go to VA, and they wanted to go somewhere else. And so I think, at that time, those changes, I was scared, but but maybe some of the changes were done for a good reason. But as far as now, going to back to what I said before, I mean, we need to keep VA staffed, adequately staffed, because a lot of people do need those services and they want them. So, yeah, I'm sorry I can't speak more to the policy stuff as to what's going
Sure.
on, but I think we should really support the VA.
So I know you're conducting clinical trials and big data studies to determine how to best link people to addiction treatment, which is obviously your overarching charge. So I'd like to discuss a couple of these projects. If you can share with our listeners what you're currently working on and what you're going to be working on.
Yeah, maybe. So I'll start by talking about a study that I'm currently conducting. It's one that is being done in the Kaiser Permanente health system. It's called the ABC study, which stands for the Addressing Barriers to Care study. and more lengthy addressing barriers to care for substance use disorder treatment. And so this study is kind of based on the idea, really, going back to what my general interests are, so few people are who need addiction treatment seek it, and even fewer end up obtaining it and engaging in it. And so, what the ABC study is doing is for people who are Kaiser Permanente members, and who they call when they call into basically a triage line for help. These folks don't know exactly where to go. Sometimes they do. Sometimes they have an idea about what treatment center to go to, but usually they don't. There's so many options. It's a very scattered treatment system. There's a lot of different places that specialize in certain types of services, and you don't always know if these treatment agencies offer what you need, or provide the services that you want, or if you even are eligible for their services in terms of insurance and so forth. And then there's wait lists and so on. So anyhow, it's kind of you really gotta to hustle to get substance use treatment, and sometimes you don't know where to start. But so this study is situated in this mental health access center where people call in knowing that they need some kind of help. They often don't know exactly where to go. They also, want to make sure that their care can get paid for. And then, what happens kind of, outside of the study, just in the real world, is people are assessed. They're provided with a really comprehensive assessment that, clinician helps really the person come to a realization about what kind of care they do need. And then they provide phone numbers to the person, and insurance authorization if needed. And so it's an amazing service, this at this mental health access center. But what they currently don't do is what our study is doing. And what our study is doing is we add on to that. And what we're doing is a program called Care Navigation that, once somebody gets, a referral to some services, like a few phone numbers to different treatment agencies, what our intervention is doing is we immediately contact this person and essentially walk their hand through the process. The intervention kind of has two components. There's one component is a motivational component to help people deal with the ambivalence of maintaining that goal of getting help and stopping their substance use. And so there's a big motivational interviewing component, and with that the second component is helping people resolve any barriers that they may experience when they go to seek treatment. So even people who are this far along, they have insurance authorization, they're ready to get care, they even have a few phone numbers of where to go, all sorts of barriers come up. People have to take time off work. They have to be able to transport to that treatment center. They may go and have there's a lot of different logistics that they have to deal with in their own life. They may need to kind of pivot. They may start treatment and feel like they need something different. And they may kind of need to pivot unintentionally. So, for instance, somebody like a medical need could come up. Somebody may need withdrawal management or detoxification, and so there's actually a lot of there's a lot of work to do for the person, and so what the care navigator does is they hold their hand through that work. They help them direct them through that work. They issue motivational interventions to help really keep their eye on the ball. And so what our study is doing is just comparing whether adding that care navigation to this treatment seeking process compared to not adding it, whether that results in more treatment initiation, more engagement in that treatment, and in general better outcomes. So that's the ABC
Any
study.
preliminary that's really interesting. Any preliminary findings? I mean, it seems quite intuitive to assume that these navigators would do all of those things.
Yeah, yeah, no, it is intuitive, and I think that that's, kind of the beauty of the study is, maybe it's not rocket science. Maybe you just need to kind of get people what they need. We don't have preliminary findings yet. We're exactly halfway through the study as of this week, so we're still actually working with people in the field. We've got 7 more months in the field. And then after that, that's where we, generate our preliminary findings. But what we have done, what data we do have is we have been working with not only the people who are calling in looking for help, but also the clinicians who are doing the assessments. We've been collaborating with them, interviewing them to learn about really what are the ways we can best design this care navigation intervention. So we've done a lot of what we call qualitative work. We didn't just kind of come up with everything on our own and do it without talking to anybody. We've involved people in this design. We've also engaged with the leaders of the healthcare system to figure out how to best kind of integrate not just within their workflows, but within how the care is organized. So, in terms of what we're learning from people is that, this is kind of exactly the work that they feel is needed, especially, with regards to that whole concept of holding somebody's hand or having somebody in your corner or having somebody to keep you accountable to your goals. Those are all
Yeah.
the things that we're hearing from people. And so hopefully, some of this will be borne out in some of our more quantitative findings when we go to analyze the trial data.
Really interesting. I'd love to have you back to talking about 7 months down the road once you're able to collect some of that preliminary stuff. It seems to me that, part of it is finding the right system, but I also have to assume that not all navigators are created equally, and this is ultimately, I think, fundamentally a human interaction. Yes.
Absolutely. Yep. That's what it is. And it's really, that human interaction, people talk about that going so far, in terms of there's a lot of self-help materials out there and stuff you can download and websites you can look at and even these days, podcasts you can listen to, and all these things are helpful, but we really can't lose sight of the value of that human connection. I think we're just as humans just so oriented to these connections and get so much out of them. It really helps not just to know somebody cares, but to know that somebody's going to check up on you.
I find it always kind of encouraging when I find things, interactions, things that people do that can't easily be replaced by AI. It's always a positive when we come upon one of those things. And I think this is ultimately one of those things. Really interesting stuff, Joe. So what else? What else you got cooking?
One that actually was just funded and that we're just getting underway is another study that we started at Kaiser Permanente that I'm still working on. Now that I've moved to Chestnut, I'm staying involved in that study. There are so many different pathways that people can take to get substance use treatment. For some people, it starts with, as I kind of alluded to before, going to an emergency department or an urgent care, and just finding out that, actually this drinking or drug use is really hurting you medically. There are people who have gone through changes in their life, not for the better, who are struggling with their substance use. Maybe it's causing problems with family, and so there's some people who realize that and kind of seek treatment on their own. There's folks who there in general there's so many different ways that people engage with the healthcare system to initially seek treatment. And within a healthcare system, you can think about all the different departments. There's primary care, you go in to talk to your doctor, the emergency department. There's, specialty care where it may be found that your, drinking is hurting, your liver, another organ system. And so people's substance use is identified at so many different touch points. And after that initial touch point, there are so many different options of where to go next. So there's really brief short-term treatments. There's outpatient treatments that are weekly, and you go in once a week and then you go home after the appointment. There's intensive outpatient treatments that are a good part of the day. There's also hospitalizations or residential treatment where you're going to stay overnight. So there's so many different pathways, and there are so many different potential turns you can take to get from one place to the next. And one of the things you really have to think about are how efficient are these pathways? How long do you have to wait to get from one place to the next? You want to know, for you, for as a person struggling with substance use, which is actually the most effective for you. And you also don't want to get lost in the system. Going from place to place every time you make a transition from this treatment to that, or from this person to that person, there's a risk of, kind of just getting lost, I guess you might say. That, as there's just so much work in getting your own medical care, let alone, having, doctors, kind of remember what path you're on, and prioritizing you when they work with so many people. So anyhow, this study, what it's doing is it's comprehensively characterizing what are all the different paths that people take. There's a multitude of them, and it's not just what is step one and step two, but what is step one, two through the end. And so we are using statistical methods. They're called, some people call them Markov modeling or multi-state models. So it's kind of a well, it's an older statistical approach that hasn't been applied to this problem before. And what we're doing is we're characterizing, what are all the ways that people go through the system? What are the most common ways? And really, ultimately, what are the most effective ways? Are there certain people that certain pathways are more effective for? Are there certain conditions like opioid use versus alcohol use that certain pathways are most effective for? And then also what, in terms of what is the quality of care that you receive? Is it better if you take, treatment A first before treatment B, and so on. So it's a really comprehensive way of analyzing all that complexity and the determining potentially which of those pathways might be the best for somebody. So that's the quantitative half, and then the qualitative half, and they actually kind of intersect. So it's what they call mixed methods. We're also identifying people. Once we establish those different pathways, we are then interviewing people who take different pathways to learn about their experiences, like what went into their choices. We're interviewing not just patients, but also the doctors in terms of what were they thinking when they sent somebody on those pathways. And so I think this is probably potentially one of the most comprehensive looks at a system as a whole, with regards to substance use treatment and the turns
Wow,
that
that
people
sounds
take.
massive.
Yeah.
What stage is this at? When do you think you'll start having some concrete findings or at least preliminary findings?
Yeah, we're just getting this launched. So the study started about 40 days ago, and we are now, get in the approval process phase. We're having kickoff meetings. We're getting all the regulatory approvals, all the ethical approvals, is really the phase that we're in. So we're still super early, and then we'll jump into all the organizing and cleaning of the data sources. And so, yeah, so I mean, like you were kind of alluding to, maybe if I'm back next year about this time, we'll have some early things that we could talk about. But ultimately, it's a multi-year study, doing the quantitative first and then the qualitative after that. So yeah, it'll be a few years before we have all the findings, but we like to get early findings out as we go.
I'm tempted to ask you if there's anything else you're working on, but I can't imagine you have any more bandwidth given the breadth of these two projects.
Yeah, no, there's a lot. I think in this field, you work on a lot of things at once, and you're able to do that because you have teams of people working on this. And so we've really blessed to work with data scientists, programmers, people who are so good at interviewing people, with these qualitative in-depth interviews, really, really good people persons, and then also other scientists that you collaborate with. So it's really, it's never one person doing the work. It's really a team effort. And you can get so much more done in that way. So yeah, typically we're as a PI, we're working on, at least 5 projects at once.
Keeps you fresh, keeps the synapses firing, right?
Yes, exactly. Yeah.
So,
Yeah.
so let me ask you one last question. A little bit of a gimmicky question, but bear with me. Uh, if a genie granted you unlimited funding, I'm sure if you came across a genie, you'd probably have a different kind of wish, but put that aside. But if it was limited to granting you unlimited funding, what's your dream project? How would you use those funds?
Yeah, that's a good question. So yeah, after I had them help me win the lotto, I think in terms of the study that I would do, I think it kind of goes back to just this question of how can we get more people in treatment when they need it or want it. And I think what I would do is I talked about the ABC study, this care navigation intervention to help people, stay motivated and get treatment when they need it and not experience and not have barriers really hurt their progress along the way. I would like to do something like that, but a much wider scope. So there has been so many good studies now on this topic. Even since 2015, when I published a review article and several editorial type articles showing and describing how hard it is to direct people to substance use care when they need it or want it. It's been such a long-standing problem, and since then there's been so many excellent studies that have tried to tackle it. So I mentioned the ABC study that, the one that we're doing. There's also been, at Lighthouse Institute, there's been the Recovery Management Checkups and Primary Care study that has a very similar goal, but it goes about it in a different way in a different population. That honestly is, part of the reason that, what put Lighthouse on the map for me, given that I study that area. There's also been really good studies about what they call decision aids. And a decision aid is kind of a booklet that helps a doctor or another clinician talk with people, with their patients to help them think about what options there are for getting treatment. So a decision aid is, it provides information to somebody who to help make a decision. And my mentor, Kathy Bradley at Kaiser Permanente, has developed one, is doing a trial on that now. So I think that's another really a great example of something, a creative way to, try to solve this problem. And then there's been, probably 100 brief motivational interviewing studies over the years, trying to help people think about what path is right for them within the matter of 5 to 15 minutes. And so there's been those. There's also been some care coordination studies, kind of like studies similar to the ABC trial that I mentioned, that have been done in hospitals. And all of these studies, I mean, these are some of my favorite studies. They're all amazing. And yet they all address one chunk of the problem. And you have to do that in research. You always just focus on one chunk, and you kind of need to do that. That's how you do experiments. But we need to do studies that focus on more than one chunk at a time. So lots of chunks. So, you've got the issue of motivation and ambivalence. You've got the issue of not knowing all the treatments that exist and which one is best for you. You've got issues related to insurance and payment and is care accessible and available and can you get there? The solution for me, Charles, is different from the solution for you. We all need something different, and as I mentioned, you really need to hustle as a person to get treatment, and you've got to stay on top of that ambivalence, not knowing if you really want to make this decision now. So with all that, I think what we need to do is we need to evaluate approaches that can help a wider variety of people get to treatment. So not just focus on one setting or one population or one system at a time. I mean, if you think about healthcare, unfortunately, it is this way, but it shouldn't be this way. We can't solve one issue if we need like 3,000 hammers in your toolbox,
Right.
right? There's just too many hammers that we're developing as researchers. And so I don't know, can we get it down to 100? I think that would be better. And so I think we should do these studies kind of more comprehensively. We need to find a way to simplify this process and not have to make different solutions every time you're in a new system. And so this is a pretty kind of like high level way of discussing the study I want to do, but in general, I think we need to get a little bit broader in how we intervene and
Yeah.
test
Yeah.
interventions. And so I have a good feeling that, I'll be in a great position to do a study like that in the next few years. Lighthouse is a perfect place to do it. Chestnut, it's so well situated in the community. You know better than I about the relationships that the system has. And also here at Lighthouse, there's a number of scientists who have, kind of similar interests as I, similar philosophy about approaching this problem that I have. And so, I think there's perfect collaborators here and really great research team staff. So I think, within the next few years, I'll be able to come up with a good idea for a feasible study that could look at this issue a little bit more comprehensively.
I probably should have reframed that, given the scope and ambition of what you'd like to get done. I think the genie would have to grant you at least two wishes.
There you go. Yeah.
Anyway, Joe, I really do appreciate you taking the time, particularly as I said, in the midst of your move. And again, let me just congratulate you on joining Chestnut. They are certainly lucky to have someone with your background doing this work.
Yeah, thank you. No, I feel like I'm the lucky one. I'm really blessed to be here and so many good people around me. So thanks, Charles.
Joe, really, again, appreciate it. Today I spoke with Joe Eglass, Senior Research Scientist with Chestnut Health Systems from his new home in Eugene, Oregon. This is Charles Epstein for the Catalyst Podcast. Thanks for listening.